Hello friends, in this session we are discussing about acute kidney injury and how to diagnose. So for diagnosis of acute kidney injury, history and physical examination plays very important role. In patient with the no prior medical data, the history may be useful for establishing whether renal function is chronic or acute. For example, a patient with the long-standing loss of appetite and the pruritus is more likely to have CKD than AKI. For these cases, a thorough history often elicits information about previous renal and urinary abnormalities such as hypertension, proteinuria, and history of diabetes mellitus. A thirsty patient or one in whom daily weight loss has been documented may have volume depletion causing pre-renal azotemia. So the exposure to nephrotoxic agent or a recent episode of sustained hypotension suggests the possibility of AT. A symptom of renal colic, abnormal voiding pattern, or history of genitourinary malignancy points towards an obstructive cause. So, about physical examination, diminished skin turgor, sunken eyes, dry mucous membrane, the absence of axillary sweat, or orthostatic hypotension suggests the diagnosis of prerenal azotemia. In disorders characterized by the reduced effective circulatory volume, such as congestive heart failure and nephrotic syndrome, prerenal azotemia may exist in the setting of expanded extracellular volume. Hypertension among patients with the AKI should raise suspicion of intrinsic renal disease. The clinician must be alert for signs of systemic disease that can cause acute renal injury, including vasculitis, endocarditis, and sepsis. Bladder distension and prostatic enlargement point to an obstructive cause. Now we'll see the KDIGO definition and classification of AK. So according to this, the diagnostic criteria for AK are increase in serum creatinine by more than 0.3 mg per dl uh, within last 48 hours, or increase in serum creatinine to more than or equal to 1.5 times baseline, which is known or presumed to have occurred within the prior 7 days, or urine volume less than 0.5 ml per kg per hour for 6 hours. And according to and the staging regarding the staging of acute kidney injury, the acute kidney injury stage 1 is characterized by increase of the serum creatinine by more than 0.3 mg per dl, or increase to 1.5 to 1.9 times from baseline. And the urine output criteria for the same is urine output less than 0.5 ml per kg per hour for 6 to 12 hours. And AKI stage 2 is defined as increase in the serum creatinine to 2 to 2.9 times from baseline, and the urine output less than 0.5 ml per kg per hour for more than or equal to 12 hours. AKI stage 3 is defined as increase in the serum creatinine more than or equal to 3 times from baseline, or serum creatinine more than or equal to 4 mg per dl, or treatment with RRT, or patients less than 18 years decrease in estimated GFR to less than 35 ml per minute. And urine criteria is defined as urine output less than 0.3 ml per kg per hour for more than or equal to 24 hours, or anuria for more than or equal to 12 hours. Now, there are certain limitations of creatinine-based criteria for AK. Now, the serum creatinine is the metabolite of creatinine, a molecule that is synthesized from the amino acid glycine and arginine in the urine, pancreas, as well as kidneys, and that served as a rapidly metabolized reserve of high energy phosphate in skeletal muscle. So the creatinine production is determined by the amount of creatinine generated in the liver, pancreas, and kidney, and creatinine ingested and muscle function. With molecular weight of 113 Da, the creatinine is freely filtered by the glomeruli. The role of creatinine as a marker of renal function is limited by the fact that its half-life is increased from 4 hours to 24 to 72 hours if glomerular filtration rate is decreased. As such, the serum concentration may take 24 to 36 hours to rise after definite renal insult. Furthermore, a true fall in GFR may not adequately reflected by serum creatinine in patients with sepsis, liver disease, or muscle wasting. Serum creatinine concentration are also affected by drugs which compete with tubular secretion. In this case, serum creatinine levels may fluctuate without change in renal function. There is also no standardized lab method for quantifying serum creatinine, and substances like bilirubin or drug that may interfere with certain analytic techniques, more commonly with Jaffe-based methods. So the serum creatinine is measured as a concentration and is therefore affected by variation in volume status. As a result, the diagnosis of AKI may be delayed or missed in patients with significant fluid shift or fluid overload. Another important limitation of all creatinine-based definition of AKI is that they require reference value to describe baseline renal function. Ideally, this value should reflect the patient's steady-state kidney function just before the episode of AKI. At present, there is no standard approach to determine baseline renal function. So, the creatinine-based criteria for AKI often do not take into account underlying renal reason. In patients with normal kidney function, a rise in serum creatinine by 0.3 mg per dl may indeed be due to important reduction in GFR. In contrast, in patients with underlying CKD, the absolute rise in serum creatinine represents variable changes in GFR, and rise by 0.3 mg per dl may be within acceptable daily variation and simply reflect the uh, inconsequential uh, changes in GFR. This is particularly relevant when diagnosing KDCO AKI stage 3, which is defined by rise in serum creatinine to more than 4 mg per dl. A patient with baseline serum creatinine of 3.9 mg per dl who experienced creatinine rise by 0.3 mg per dl in last 48 hours would be classified as having KDCO AKI stage 3, whereas such a rise would be defined as AKI stage 1 in patient with normal baseline renal function. Similar problem may occur when defining AKI stage 3 by RRT criteria. So the optimal timing of the RRT for AKI is not known, and clinical practices vary. So finally, a single serum creatinine values do not provide any information about specific stages of AKI process. Importantly, they do not indicate whether a patient is still in progression phase or in recovery has already begun. Also, EGFR formula are not valid to determine renal function in AKI. So there are certain limitations of urine-based criteria for AKI also. So the urine output is important clinical marker, but like creatinine is not renal specific. In fact, renal urine output may persist until renal function almost ceases. So similarly, oliguria may be an important physiological response of functioning kidneys during period of prolonged fasting, hypovolemia after surgery, following stress, pain, or trauma. In this situation, the action of ADH can result in generation of very concentrated urine with osmolarities up to 1400 m osmol per liter. Assuming daily solute of load 700 m osmol per m osmols, the urine volume may physiologically decrease to 500 ml as a result of normal kidney function. So the critical criteria for AKI are based on the presence of oliguria for minimum 6 hours. And several experts have questioned the validity of this arbitrary cutoff and suggest using either longer minimum period, that is for at least 12 hours, or a lower threshold for urinary output, that is zero point 0.3 ml per kg per hour instead of 0.5 ml per kg per hour to reach sufficient specificity for diagnosis of AKI. Finally, in obese patient, weight-based urine output criteria may be particularly misleading. So in fact, the European renal best practice guideline recommended using the ideal weight rather than true weight when calculating urine output in ml per minute per kg to avoid overdiagnosis of AKI. So new AKI biomarkers. Biomarkers for AKI can be stratified into marker primarily reflecting glomerular filtration, like serum cystatin C, glomerular integrity like albuminuria, proteinuria, tubular stress like insulin like growth factor binding protein 7, tissue inhibitor metalloproteinase 2, urine for urinary damage, for tubular damage, neutrophil gelatinase associated lipocalin, kidney injury molecule that is KIM1, and acetyl BD glucose aminidase that is NAG, and liver fatty acid binding protein and intrarenal inflammation interleukin 18. The availability of this new biomarker has allowed the detection of subtle changes in the renal function before serum creatinine rises, and the identification of the patient with evidence of the kidney injury without changing serum creatinine, that is subclinical AK. Of note, biomarker positive and the creatinine negative patient appear to have greater risk of complication, a longer stay in hospital, high mortality compared to patient without biomarkers. A commercial kits for the measurement of cystatin C and GAL, IgBT7 and TIM2 are available. To date, only cystatin C is routinely used in some hospitals. Cystatin C is the low molecular 13 kD inhibitor of lysosomal proteinase and extracellular inhibitor of cysteine proteases. It is produced in all nucleated cell and can be found in all tissues and body fluids. It is freely filtered in the glomeruli and then fully absorbed by tubular cells and broken down. Since there is no tubular reabsorption or secretion, it is considered a better marker of GFR than serum creatinine. The main strength is that cystatin C is less dependent on age, gender, muscle mass, and liver function. However, cystatin C has been reported to be altered in some patients with cancer, thyroid dysfunction, steroid therapy, and smokers. Now, the next is urine test for diagnosis of AKI. The lab evaluation should commence with urine analysis. The measurement of urine osmolality, electrolytes, creatinine concentration are simple and useful, particularly for differentiating between ATN and perirenal azotemia. Urine-specific gravity can be measured at bedside. A high urine-specific gravity generally correlates with the concentrated urine and is expected in perirenal azotemia, except in presence of now, next is urine deep stick test. The familiar deep stick test provides a readily available method for determining whether the urine contains protein or heme pigments. When positive, they should raise the suspicion of intrinsic renal pathology. As deep stick test for the protein measures only albuminuria, based on protein will not be detected. Urine deep stick testing is simple test to undertake. In fact, the AKI guideline by National Institute for Health and Care Excellence in UK recommends performing urine dipstick testing for blood, protein, leukocyte, nitrite, and glucose in all patients as soon as AKI is suspected or detected in order not to miss any potentially treatable glomerular and tubular pathologies. These include glomerulonephritis with hematuria and proteinuria, acute pyonephritis with pyuria, leukocyturia, and nitrite in urine, interstitial nephritis, occasionally with eosinophils. It is important to consider the result of urine dipstick alongside the clinical history and evaluation of the patient. For instance, the presence of white blood cell is non-specific but may indicate underlying infection and acute interstitial nephritis. Similarly, the deep stick hematuria in patients with indwelling urinary catheter can have multiple etiologies ranging from glomerular nephritis to simple trauma. A deep stick detects hemoglobin and remain positive even after red cell lysis. They also detect hemoglobinuria from intravascular hemolysis as well as myoglobin from muscle breakdown. A urine dipstick positive for hemoglobin without red cell positivity suggests possible diagnosis of rhabdomyolysis. Light chains can be detected by urine protein electrophoresis and immunofixation. Daily urine protein excretion can be quantified by 24-hour urine collection. Although influenced by several potential confounding variables, the urine protein to creatinine ratio from random urine specimen rapidly provides a gross estimate of the degree of protein. Formed element in the urine sediment yield invaluable information about the nature of AK, particularly in the intrinsic renal disease. The presence of RBC cast distinguishes the hematuria associated with the glomerulonephritis from that of the post-renal or the urological causes. Broad and the waxy cast suggests the renal disease is chronic. Virtually any lesion that can cause obstruction in genitourinary tract can produce hematuria. Crystalluria often occurs in association with the obstruction due to renal calculi or medication. Now, these are the pictures which shows the interpretation of the urine microscopic finding and the inter. So next is urine electrolytes. The first is the functional excretion of sodium, which can indicate the degree of renal sodium avidity, which generally reflect renal perfusion. A value of less than 1% typically indicate prerenal azotemia. However, this test can be confounded by concomitant diuretic therapy that will enhance the urinary salt loss. In this situation, the fractional excretion of urea can be used instead because urea clearance is unaffected by diuretics. The fractional excretion of urea is calculated via same formula as fractional excretion of sodium, but substituting urea for sodium. A value of less than 35% is suggestive of renal hypoperfusion. Urine microscopy can provide very valuable information when performed by skilled operator using freshly collected non-catheterized urine sample. It is not utilized very often in ICU predominantly because it is operator dependent and requires training and experience. When done properly, the presence of red cell cast or dysmorphic red cell suggests the diagnosis of glomerular disease. Urine microscopy may also help to diagnose septic AKI and predict the worsening renal function. Bagshaw and the colleague collected blood and the urine samples of 83 critically ill patients with sepsis, of whom 52% have AK. They derived urine microscopy score on the observed quantification of renal tubular epithelial cell and granular cast in sediments and showed that septic AKI was associated with the greater urine microscopy evidence of kidney injury compared to non-septic AKI, despite similar severity of the AKI. Higher urine microscopy score was also predictive of worsening AKI. Finally, urine microscopy can be informative in a rare cases of AK. For example, ethylene glycol poisoning, where oxalate crystals may be seen in case of tumor lysis syndrome, where urate crystal may be present, or in light chain disease. Now, the next is blood test. The measurement of blood urea nitrogen and creatinine is essential to identifying and monitoring AK. As noted, the ratio of blood urea nitrogen and creatinine carries the sum diagnostic value. As high value more than 20:1 may indicate prerenal azotemia. Serial blood chemistry will help identify acid base and the electrolyte disturbances common with the AK. Anemia may suggest the more chronic form of kidney disease, and eosinophilia frequently accompanies acute interstitial nephritis. Now, the next is autoimmune profile. Depending on the clinical context, the clinical signs, and the urinary dipstick results, the patient may require specific immunological test, including anti-neutrophil cytoplasmic antibody, that is ANCA, anti-nuclear antibody, that is ANA, anti-glomerular basement antibody, that is anti-GBM, and the complement C3, C4 to rule out immune-mediated disease like vasculitis and connective tissue disorder. These investigations should be considered mandatory in patients with AKI presenting primarily with the pulmonary renal syndrome, hemoptysis, hemolysis, and thrombocytopenia. Now, the other lab tests. Depending on the clinical context, the following tests may be indicated, like serum creatinine kinase and myoglobulin in case of suspected rhabdomyolysis, their lactate dehydrogenase in case of suspected TTP, that is thrombotic thrombocytopenic purpura, and the fragmentocytes in case of possible TTP and hemolytic uremic syndrome, and terminal pro-BNP and troponin in case of suspected cardiorenal syndrome, serum urine protein electrophoresis in case of suspected myeloma kidney. So this is the flow chart which showed how should we approach in the different clinical in different clinical scenarios in when we are encountering the case of AKI. Like whenever we are dealing with the case of acute kidney injury, the fall we should first we should send a full blood count with differential, then urine dipstick, urine microscopy, urine sediment, renal ultrasound sonography, serum calcium, serum electrolytes, urea, uric acid, and osmolarity. If cause of AKI still remains unclear and hypovolemia obstruction is excluded and any of the above investigation is abnormal, then consider following investigation depending upon the clinical context and sign. So for the if we are suspecting the etiology like glomerulonephritis and vasculitis, then we can send order for the other investigations like ANCA, ANA, anti-GPM, anti-dsDNA, C3, C4, immunoglobulins, cryoglobulin, hepatitis serology, HIV serology, and renal biopsy. If we are suspecting etiologies like interstitial nephritis, then other investigation that we can order is eosinophilia, eosinophiluria, and renal biopsy. If clinical picture, if it's suggestive of abdominal compartment syndrome, then we can measure intravascular pressure. If from clinical scenario, if we are suspecting the conditions like TTP, HUS, then we can order for LDH, fragmentocytes, platelet, reticulocytes, hepatoglobulin, and bilirubin. If there is rhabdomyolysis, then kindly order for creatinine kinase and myoglobulin. If myeloma, if you're suspecting myeloma, then serum, urine protein electrophoresis, renal biopsy. In case of sepsis, sepsis screen include blood culture, urine culture, and inflammatory biomarkers. In case of cardiorenal syndrome, we should check the levels of troponin, CKMB, NT-proBNP, and cardiac imaging. Now we'll see radiographic studies. Various radiographic techniques may contribute to the evaluation of AK. Renal ultrasonography, it is a safe and quick high-yield procedure and is probably the first radiographic test that should be ordered in the evaluation of any azotemic patient. It permits the identification and measurement of both kidneys and is very sensitive for detection of obstructive uropathy. This is a sonogram with the right hydronephrosis. So helical CT, with or without contrast. It is a versatile and high-yield technique for establishing the size of kidneys and recognizing hydronephrosis. But contrast administered during the test can result in AKI in patient at increased risk, such as those with renal insufficiency, hypovolemia, or multiple myeloma. So this is the computed tomography scan with the right hydronephrosis. Unobstructed kidney is shown for comparison on the right side of the image. Note enlarged pilocalcial system on the left side of the image. Now the next is magnetic resonance imaging offers the similar data as the helical CT, but is less commonly used because of the cost and the availability. The use of gadolinium contrast should be avoided if possible in setting of AKI due to risk of nephrogenic systemic fibrosis. Retrograde pyelography is the reserved for patients in whom urinary tract obstruction is strongly suspected, despite the inability to confirm this finding on the other imaging technique. It is generally performed in anticipation of relieving such obstructions as soon as they are identified, usually by placement of urethral stent. Isotopic renal scanning provides a safe means for locating kidneys and allow the estimation of their functional capacity. Radionuclide flow study can be used to assess the rapidity of uptake and tracer by the kidney. A delay in uptake helps to establish the diagnosis of impaired renal perfusion, whether due to structural renovascular disease or functionally impaired renal blood flow. Prolonged retention of radioisotope by kidney is suggestive of outflow obstruction. Radioisotopic scanning may be particularly helpful in assessing patients with prolonged AKI for absence of blood flow and the possible diagnosis of cortical necrosis or renal infarction. Now, this is the diagram which showed the renal radioisotopic scan demonstrating poor uptake of tracer in patient with left renal artery occlusion. So in A, that is the picture that we are showing, the picture that it's suggestive of the early flow phase in which each panel represents a 2-second interval and the scintigraphic activity is seen in proximal aorta and right kidney. There is absence of tracer activity over the area of the left kidney. And B picture is the functional scan with each panel representing 1-second interval. Note the marked diminution of scintigraphy activity over the left kidney. Now, the renal artery duplex scanning offers the alternative method of assessing renal artery flow. Although non-invasive, the test requires a significant operator expertise. In cases in which a high degree of sensitivity and specificity is required, CT and MRI aortogram or even full renal arteriography may be necessary. Arteriography is more invasive but offers the opportunity for immediate therapeutic intervention such as angioplasty and vascular stenting. Now the next is renal biopsy. Renal biopsy is reserved for patients who are thought to have parenchymal renal disease. The indication for renal biopsy are the matter of some controversy, but the procedure should be considered when azotemia is of recent onset and unknown origin. There is a possibility that patient has the renal disease that may require drug treatment, for example, steroid or cytotoxic drug, as in patient with the probable glomerulonephritis, vasculitis, and AIN, that is acute interstitial nephritis. And heavy proteinuria or nephrotic syndrome is present, or renal biopsy result might be of prognostic importance. Now, utility of ultrasonography for the evaluation of kidney injury. Ultrasonography is the primary imaging modality for evaluation of AKI, and it is important component of competence in the critical care ultrasonography. So equipment that we are using for imaging kidney is a curvilinear probe designed for abdominal imaging. Alternatively, phased array cardiac probe gives the serviceable images when configured with the abdominal preset. Now the scanning techniques. With the patient in supine position, the probe is placed in the posterior axillary line over the lower lateral chest wall in order to obtain transpostal coronal plane view of the right or a left kidney in the longitudinal axis. Useful landmark for locating kidneys are liver or spleen, as the kidneys are adjacent and caudal to the organs. The inexperienced scanner often scans the two anterior a plane to locate the kidney. A useful rule to locate the kidney is to place knuckles on the bed when operator is positioned ipsilaterally and scanning the contralateral kidney. This result is appropriately posterior scanning plane. Once identified, the probe is angled through kidney to obtain the multiple tomographic section of the structure. The operator may rotate the probe counterclockwise by 90 degrees to obtain transverse view of the kidney while angling through it to obtain multiple tomographic views. The bladder is imaged by placing the probe just above the pubic bone in the midline. Using transverse scanning plane, the scanning plane is angled in the caudal direction to identify the bladder. Once identified, the probe is angled through the bladder to obtain multiple tomographic views of the structure. The operator may rotate the probe clockwise by 90 degrees to obtain longitudinal view of the bladder while angling through it to obtain multiple tomographic views. A Doppler analysis of renal blood flow has some application for assessment of AKI but requires training above the level typically needed by intensivists. Now, ultrasonography anatomy. Kidney size. Normal kidney size is 9 to 12 centimeter in length. Chronic kidney disease results in reduction of the kidney size. AKI may result in the enlargement of the kidney size. Now, kidney parenchyma. The kidney parenchyma is found by the outer renal cortex and centrally located medulla, which contains the renal pyramids. The renal calyces may be predominantly interposed between the pyramid, and this is the normal variant. Normal parenchymal thickness is 1 to 1.8 centimeter and is diminished into CKD. Normally, renal parenchyma is hypoechoic when compared to the adjacent liver and spleen, and the cortex is slightly hyperechoic relative to the underlying medulla. Both AKI and the chronic kidney disease results in hyperechoic parenchyma when compared to adjacent liver or spleen. Now, kidney margin. Outer boundaries of the kidney is defined by xerota fascia and perinephric stand. Normally, it is smooth. Persistent fetal ovulation result in distinct V-shaped indentations that are normal variant. Now, pelvocalciare area. The central pelvocalciare area contains the collecting system, then sinus fat, and the renal vasculature. It is the hyperechoic and the demarcated from surrounding renal parenchyma. Chronic renal failure is associated with the loss of demarcation between pelvocalciare area and the parenchyma. The normal collecting system is not visible. Obstructive uropathy results in the dilatation of collecting system. Now the bladder. Bladder is well defined when filled with urine. The normal bladder is in midline location and its symmetrical organ with thin, smooth walls. When non-distended, wall thickness is increased. The empty bladder may be difficult to locate unless catheter balloon is inflated inside. It may be difficult to distinguish distended bladder with coexisting ascites. The operator searches for bowel structures within the fluid-filled structure and their presence indicate ascites. If uncertainty persists, the injection of agitated saline into bladder catheter with real-time imaging will generally resolve the issue. Now, the clinical application. Obstructive uropathy is the potential reversible cause of AKI, so it is important to rule out the entity in patient who has renal failure in ICU. The examination can be performed in a short period of time and it is an essential part of competence in the critical care ultrasonography. It includes the examination of both kidneys and bladder. The finding of hydronephrosis include dilatation of renal pelvis and calyces by urine with thorough transmission artifact. It can be classified as mild, moderate, and severe. Acute obstruction result in calyceal dilatation that ends with the acute angle point. In chronic obstruction, the calyceal dilatation ends in curvilinear manner. In long-standing hydronephrosis, the renal parenchyma is thinned and dilated collecting system occupies most of the kidney profile. The presence of hydronephrosis is not necessarily associated with reduction in the urinary flow. The obstruction may be unilateral, so one kidney continues to function, or it may be partial with sufficient pressure backup to harm the kidney but with continued urine flow. Ultrasonography may identify the source of obstruction if it is in the collecting system of the kidney, for example, kidney stone and malignancy. However, ureter is difficult to reliably identify with the ultrasonography, even if dilated. CT scan of the retroperitoneum is the definitive imaging modality for this area. If the obstruction is at the level of bladder, ultrasonography is useful to identify bladder tumor, blood clot, and the prostatic enlargement as a cause of hydronephrosis. An occasional cause of anuria is the blocked bladder catheter. The occasional cause of anuria and the presence of catheter tip in the balloon within the distended bladder indicates the blocked catheter that can be flushed clear. The presence of inflated balloon within the empty bladder indicates the patent catheter, and if there is urine output, an anuric patient if there is none. The finding on ultrasonography of the kidney in patient with the medical cause of renal failure are non-specific. The kidney may be enlarged with the loss of medullary cortical interface, and the cortex is typically hyperechoic in comparison to adjacent liver or spleen. The examination is not useful in categorizing the etiology of the AKID. Chronic renal failure results in the small hyperechoic kidneys with the reduced parenchymal thickness, loss of differentiation between parenchyma and the pelvocalciare area. In end-stage renal disease requiring dialysis support, the kidney may become so small and hyperechoic that it is difficult to locate with ultrasonography. So the limitations of ultrasonography for evaluation of AKI is the identification of hydronephrosis. The obstructive uropathy may take up to 24 hours to manifest with hydronephrosis, so it is appropriate to repeat examination if clinical situation remains ambiguous. The patient with the severe medical renal injury may have no urine production or by the kidney. This will obscure the presence of urinary tract obstruction because with absent kidney function, there can be no hydronephrosis in unlikely situations where there is dual diagnosis of severe medical renal failure and obstructive uropathy. Rarely infiltrative disease of the kidney restrict the enlargement of collecting duct and the presence of downstream obstruction. Renal cyst. Renal cysts are common incidental finding that may be unilateral bilateral. They are often located in the renal parenchyma at the poles of kidney and occur in the wide variety of sites. Occasionally, they are in pelvocalcare area, may be confused with hydronephrosis. A simple renal cyst is anechoic and with thorough transmission and with through transmission artifact has no wall thickness and is completely absent of internal echoes. Now the next is renal mass. Renal mass is occasional incidental finding regardless of size or location. This requires radiological consultation. Then the next is renal stone. Renal stone is composed of echogenic material, appears as hyperechoic structure within collecting system of the kidney. They may be single or multiple in number and characteristically exhibit acoustic shadowing artifact. Ureteral stones are difficult to identify with the ultrasonography. Renal stones in association with the ipsilateral hydronephrosis may concern that there is a stone impacted in the ureter. Then renal abscess and pyelonephritis. An intraparenchymal and perinephric abscess appear as a complex hypoechoic mass with the irregular wall. Pyelonephritis does not have specific feature on ultrasonography examination, with the exception of emphysematous pyelonephritis, where there is a characteristic pattern of air collection within the kidney. If there is a suspicion of renal infection on ultrasonography examination, radiology consultation is indicated. Now the next is bladder pathology. Bladder mass is occasionally incidental finding that requires radiology consultation. Bleeding from kidney and bladder may result in thrombus that can obstruct the drainage of the bladder. This may be difficult to differentiate from the bladder tumor. Bladder irrigation with the removal of thrombus is diagnostic. Bladder irrigation may be performed with real-time ultrasonography imaging to aid in the clearing thrombus. A large prostate may protrude into bladder. Radiology consultation is required to further characterize any bladder mass. Then next is difficulty with bladder catheter insertion. If insertion of bladder catheter is difficult, it is useful to guide the insertion. A site of obstruction is usually an enlarged prostate. Ultrasonography allows the operator to avoid the complication of inadherent inflation of the balloon within the prostate. This occurs when the tip of the catheter is in bladder, but the deflated balloon has not been passed into bladder. The urine flow is noted into tubing and the balloon is assumed to be in the bladder. The balloon is inflated, thereby causing injury to the proximal urethra and prostate. With difficult bladder catheterization, catheter and balloon can be seen in real-time scanning within the lumen of distant bladder before the balloon is inflated. Thank you.